Thank you so much, Dr. Mariam. Thank you so much for this nice introduction. So, first of all, I want to thank Professor Sehnaz and the organizing committee for giving me the opportunity addressing you. It's wonderful to come back after this pandemic, again back to Egypt, to Cairo. COVID-19 has been disruptive to all living areas. It tested the resilience of both the global healthcare systems and the economies to emerging crises. It has shown how fragile our health systems and economies are. There were marked differences between the countries in how they managed the pandemic, how they maintained the health of their citizens and their economies. The magnitude of inequalities were more profound. Back in 2015, the United Nations decided on a universal set of goals, targets, and indicators that UN member states will be expected to frame their agendas and political policies to reach them till 2030. A universal call to action that provides the blueprint for shared prosperity in a sustainable world. The SDGs sound aspirational when they were set, but in real world, difficult to reach to all of them everywhere in the world in 15 years, and then the COVID, of course, the pandemic. And it looks like the COVID-19 pandemic caused disruption in several of them. This is also reflected in the UN SDG 2022 report published this year in July. These will affect the clinically vulnerable groups like people with diabetes more than others. About 2 years after the WHO formally declared coronavirus as global pandemic, the first goal, the first goal of these SDGs is to end poverty in all forms everywhere in the world. The report states that the pandemic has negatively affected progress in poverty reduction over the past 25 years. In 2019, the number of people with the extreme poverty, meaning people living on less than $1.9 US dollars a day, was estimated as 641 million, and if the decline continued, the projection for 2022 was 581 million. Nowcast suggests that the global poverty rate increased sharply from 2019 to 2020, from 8.3% to 9.2%. This means that an additional 93 million people worldwide were pushed into the extreme poverty because of the pandemic. This erased more than 4 years of steady gain. We will probably have worse outcomes in the coming year because of the COVID-19 after effects, combined with other crises like rising inflation all over and the war in Ukraine. The second SDG is zero hunger. The COVID-19 pandemic exacerbated an already worsening situation due to climate change, conflicts, economic shocks, among others, with 150 million more people facing hunger in 2021 than in 2019. It is estimated that altogether about 828 million people suffered from hunger in 2021, nearly 1 in 10 people worldwide. In addition, nearly 1 in 3 people were moderately or severely lacked regular access to adequate food. This represents an increase of almost 350 million people since the beginning of the pandemic. The third SDG is about healthy living. The pandemic has severely disrupted health systems and essential health services. Interruptions in essential health services were reported in 92% of 129 countries surveyed at the end of the 2021. An important economical issue for the diabetes community is universal health coverage. This report says data are not yet available to provide a comprehensive look at the impact of COVID-19 on universal health coverage. But since the pandemic has led to a significant disruption in essential health services, the progress made over the last 2 decades has likely come to a halt. With the combined health and economic impacts of COVID-19, people may be facing greater financial constraints in accessing care. Among those paying out of pocket for health services, financial hardship is likely to worsen further, particularly for those already disadvantaged. Diabetes is in all living areas, and all SDGs can be related to our cause. But as the topic of this talk is about socioeconomic challenges, I tried to pick up the ones that are this way or that way related to this topic. So I'm going over to the 8th SDG that includes economic growth. As stated again in this report, COVID-19 precipitated the worst economic crisis in decades. Although the economy began to rebound in 2021, bringing some improvements in unemployment, recovery remains elusive and fragile. Recovery varies significantly across regions, countries, sectors, and labor market groups. Developed economies are experiencing a more robust recovery, while least developed countries struggle with weak economic growth and labor market fallout due to workplace closures. Many small firms, particularly those in low and lower middle income countries, are especially disadvantaged, with limited capacity to remain viable. And lastly, the effect of pandemic on reduced inequality, the SDG 10. COVID-19 increased relative poverty in many countries. The concern about the disruption in economies have also been shared by several reports by other international organizations or institutions like OECD, World Bank, IMF, among others. People with diabetes have been among clinically vulnerable groups during this period, and it's still not over. There are several reasons for that. First of all, the huge number of people with diabetes. When COVID-19 hit us in December 2019, in the first months of 2020, diabetes continued to be a major health concern all over the world. According to IDF estimates at that time, there were 463 million adults living with diabetes worldwide, which is about 9.3%. In 2021, the prevalence of diabetes increased further to 537 million adults living with diabetes worldwide, about 10.5% of the world's adult population. Globally, 1 in 2 adults living with diabetes are undiagnosed, which makes the case for complications more complicated. 87.5% of all undiagnosed cases are in low and middle income countries, with low-income countries having the highest proportion undiagnosed in 2019. Then diabetes is also a costly disease. Diabetes-related health expenditure is rising globally throughout the years. In 2019, IDF estimated that total diabetes-related health expenditure was about $760 billion US dollars, and in 2021, it grew to $966 billion. In 2021, 11.5% of total global health spending was spent on diabetes. Like in 2019, the SACA region of IDF had the highest percentage, followed by this region, the Middle East and North Africa region, among IDF regions. Despite being home to nearly 41% of people with diabetes in the world, the SACA, MENA, Africa, and Southeast Asia regions are collectively responsible for only 12.5% of global diabetes-related health expenditure. There is a huge diversity regarding the mean annual health expenditure per person with diabetes across countries. While Switzerland, US, and Norway have the highest yearly diabetes-related expenditure per person, at least 49 countries have less than $365, so less than $1 a day. The cost of diabetes is mainly due to its complications. This is a study about the total economic burden of diabetic retinopathy and other visual disorders on the US healthcare system. They estimated 3 components: direct medical costs, other direct costs, and productivity losses. Other direct costs included items like nursing home care attributable to visual impairment, and government purchase programs. They used the private insurance and Medicare and commercial claims databases to estimate the direct medical and non-medical costs and productivity losses among US adults aged 40 years or older. Treatment in the outpatient settings was associated with the highest direct medical cost in people with diabetes, aged 40 to 64 years, with an average treatment cost per patient of approximately $629 per year. In addition, long-term care or nursing home costs due to visual disorders totaled 11 billion US dollars. And if we think about the number of people with diabetic sight-threatening retinopathy, then these numbers are very high. Another study again from US, they compared the direct and indirect cost of employees with diabetic retinopathy to employees with diabetes, but without retinopathy, serving as controls. The mean annual total cost of the employees with diabetic retinopathy were $18,218 compared to nearly $12,000 among the control group. So there was a significant cost difference of about $6,300. Cost differences were larger across employees with diabetic retinopathy subgroups, like patients with diabetic macular edema versus without, patients with proliferative retinopathy versus without proliferative retinopathy, and patients who underwent photocoagulation versus not, and patients who underwent vitrectomy operation versus not. Again, all the expenditures were much higher in the people with sight-threatening disease. IDF European region ran a survey between August and October 2020 during the first wave of COVID-19 pandemic. They included 3,480, the responses from 3,480 people living with diabetes across 32 countries in Europe. So I will try to go directly to the questions that this way or that way deal with the finances. You can reach these reports at the IDF Europe website. People were asked how they would rate their ability to manage their diabetes during that time, during the first COVID wave. In general, it worsened as we would expect, and 25% of the respondents reported that they could not manage their diabetes, not very effectively or not at all, before the COVID period as well. But this rate increased to 39% during the first wave. Financial sustainability was a core issue for all, including people with diabetes. About a quarter of respondents experienced some financial concerns, but severe geographical inequalities are unfortunately not reflected in these responses and also not in the report. But at the end, this was more pronounced in middle-income and low-income countries. So there is also a section in the 10th edition of Diabetes Atlas published in 2021 on COVID-19. When we look there, the IDF regions with the highest cumulative number of COVID-19 infections were Europe, North Africa and Caribbean, and South and Central America. But of course, the thing is, these are the reported numbers from the countries and the regions. So probably the new Diabetes Atlas will give us more information about the COVID-19 in the regions. So if we speak about the good care, whether we are close to the targets or not, then we have to take the socioeconomic factors that has a huge effect on our ability to afford medical care, manage our disease, make health choices or more, and more. I wonder how many people with diabetes in the world are lucky enough to have regular screening for complications and to access to the treatment one needs. We need to establish more resilient and sustainable systems in order to provide the most vulnerable people with diabetes with the health care they need. So thank you.